Hi class, my name is Sarah Smith. This week's discussion is going to focus on the nursing assessment of the chest and lungs. Prior to completing a physical assessment, the nurse should conduct an interview with the patient, including questions concerning current or former use of tobacco or nicotine, whether or not there's a history of recurrent respiratory infections, if the patient is experiencing increased shortness of breath at rest or with exertion, if there's a persistent or productive cough, and if the patient has been exposed to environmental toxins or experiencing chest pain with breathing. The next steps in this discussion will include explanation of how to complete a physical assessment of the chest and lungs, along with normal and abnormal findings. Conducting a physical assessment of the chest and lungs includes 4 steps. These include inspection, palpation, percussion, and auscultation. Per our Jarvis textbook, inspection of the posterior chest includes viewing the patient's respirations and any use of accessory muscles. Skin color and condition, chest rise and fall with inspiration and expiration. Next is palpation of the posterior chest. To palpate the posterior chest, the hands are placed at the posterolateral chest wall. The thumbs will pinch a small piece of skin, and then as the patient is deep breathing, the thumbs should move symmetrically, showing normal lung expansion. We can then assess tactile fremitus by palpation. While the patient repeats the words 99, we can start palpating the lung fields from side to side with the balls of our fingers.
99.
Normal tactile fremitus should produce symmetrical vibrations, as I said. Once this is completed, we can move to percussion of the posterior chest. Starting with the upper lung fields, moving side to side, we will gently tap the fields, noting any areas of dullness, resonance, or hyperresonance. Resonance is a normal finding in a healthy adult, and the sound produced by percussion is low-pitched and hollow. We then move on to auscultation of the posterior chest. With this, we use the diaphragm of the stethoscope and move from one lung field to the next, starting with the superior portions of the lungs. During auscultation, the patient will be instructed to breathe normally as the nurse listens to breath sounds. Normal lung sounds are high-pitched in the superior lung fields, and then as we move down, they become softer. Once auscultation of the posterior chest is completed, we can move on to the anterior chest. We will inspect the chest for any discoloration or lesions and also note shape of the chest. From our health assessment textbook, a normal chest should have symmetrical intercostal spaces with downward sloping ribs. An article within Lung India describes barrel chest as an abnormal shape that can be associated with progressive COPD. With this condition, the upper chest is pushed out because of horizontal ribs. As the lungs persistently hyperinflate due to airway resistance, the rib cage remains partially open and causes the barrel chest shape. The process for evaluating the anterior chest is similar to the posterior chest evaluation. Palpation of the anterior chest involves placements of the hands on the anterolateral wall with the thumbs pointing towards the xiphoid process. As the patient breathes deeply, the thumbs should move out with expansion of the lungs. Then we go through the steps of percussion, palpation, and auscultation. Thank you very much.